Risk adjustment clinical documentation specificity. Today we'll be talking about depression and mood disorders. We'll look at the diagnosis specificity needed in order to assign the diagnosis code to the highest specificity, and the clinical documentation required to support that diagnosis code submitted on your claim. Information shared today is for educational purposes only, using 2021 data for accuracy at the time of delivery. The guidance is to be used for easy reference. However, the ICD-10 CM codebook and the official guidelines for coding and reporting are the authoritative references. Specific documentation examples are reflective of the clinical thought process. The information shared today serves to enhance your implementation of high-quality clinical documentation for ICD-10 coding accuracy to the highest level of specificity. The goal for today's content is to obtain a high-level understanding of risk adjustment specific to depression and mood disorders. We'll be utilizing the CMS-HCC Medicare Risk Adjustment Model. The information is in accordance with the ICD-10 coding guidelines, CMS Risk Adjustment Data Validation Guidelines, the American Hospital Association and Coding Clinic, and industry best practice suggestions for risk adjustment success. We hope that you learned one thing today that you didn't know or that wasn't clear about risk adjustment, clinical documentation, and/or ICD-10 coding, and the ultimate goal is that you take away one tip to ease the documentation requirements and the burden in your day-to-day. Just a brief review on best practice for clinical documentation specificity. Specific to risk adjustment data validation audits, recall it's that one standalone progress note. It's not the medical record in its entirety that's used in an audit. It's one data service and a single progress note that must validate the ICD-10 diagnosis codes that were submitted on your claim for risk adjustment data validation. Does the clinical documentation in your progress note meet the CMS acronym MEET criteria to support the diagnosis codes assigned on your claim for submission? Remember, monitor, evaluate, address, treat the diagnosis. Specific to depression and mood disorders, some tips for success in risk adjustment data validation. Mood affective disorders, ICD-10 diagnosis codes F30.X through F39. HCC category 59 is called major depressive, bipolar, and paranoid disorders. There are 58 ICD-10 diagnosis codes that map to mood affective disorders, which is HCC 59, with a risk weight of 0.343. 26% of all Medicare beneficiaries, greater than 13 million, have a diagnosis of F32.9, depression unspecified. Just a quick note that HCC 59 does not include anxiety, which is not in the risk adjustment model. Some common costs associated with depression are medications, specialty visits, in- and outpatient therapy. These costs alone are reason to add the specificity needed for accurately coding if known. Use of the active medical problems list to your advantage is perhaps one of the things to be successful with the requirements for depression. Choose a narrative that specifies your patient depression and use that to drive your clinical documentation. Here's an example of the CMS crosswalk for HCC 59, major depressive, bipolar, and paranoid disorders. You can see on the left the ICD-10 diagnosis code, in the middle the diagnosis descriptor, and on the right the HCC that diagnosis maps to. The most commonly submitted diagnosis for depression is F32.9, which is not included in the risk adjustment model. It codes out to major depressive disorder, single episode, unspecified. Depression and ICD-10 coding according to the American Hospital Association. In the ICD-10 index under depression, you'll see acute, mental, major, or single. When your clinical documentation lacks the details needed to accurately code depression, it will automatically default to code F32.9, unspecified depression, that's not included in the HCC model. F32.9 default code codes to things such as major depressive disorder, single episode, major depressive disorder, unspecified, depression, depressive disorder, or major depression. Recall that the diagnosis code submitted on your claim should reflect your patient's accurate health status for appropriate funding. Accuracy of the active medical problems list is best practice for success in risk adjustment. Use the narrative specificity to your advantage to drive your documentation for each encounter. When it comes to depression, there are specific elements required. So instead of just choosing depression or major depression or depressive disorder, which codes to F32.9 as a default code not included in the risk adjustment model, use your active medical problems list and the narrative provided to get you to the depression specificity that you need, such as major depressive disorder, recurrent, in full remission, which would code out to F33.42 HCC 59. And just as an informational purpose, anxiety, disassociative, stress-related, and/or other non-psychotic mental disorders, codes F40.X through F48.X, are typically not included in the CMS-HCC risk adjustment model. There are only 3 diagnoses specifically related to dissociative conditions that are in the risk adjustment model under this coding category. Best practice for documentation of depression, the 1, 2, 3s. Your clinical documentation for depression should always include the status of the depression, the specificity of the depression, and the treatment plan for the depression. So the status would be stable, single episode, recurrent, etc. Specificity would be depression versus mild, recurrent, major depressive disorder. And then your treatment plan would be things such as managed by a psychiatrist or continue medication. Be sure to document and code all behavioral health conditions as appropriate when addressed in the encounter. Even when the diagnosis is currently managed by a specialist, incorporating documented complications from specialist notes into your current documentation and the patient's active medical problems list is a recommended best practice for primary care physician awareness and to ensure conditions are monitored appropriately. Documentation solely in a problems list or past medical history list is not sufficient to show for the CMS acronym MEET documentation requirement. Recall, we need the diagnosis and what you're doing to monitor, evaluate, address, and treat that diagnosis. Documenting and coding for depression. Recall the best practice of the 1, 2, 3s to include the status, the specificity, and a treatment plan for your depression. Documentation should also include, at a minimum, descriptive terms for the severity and the episode. Is it mild, moderate, or severe? Is it a single episode or a recurrent episode? And the remission status should also be documented as appropriate. Documentation of a diagnosis for depression, major depression, and even chronic depression without further specificity is not included in the risk adjustment model. Documentation should be consistent throughout the encounter note, including your HPI, physical exam, review of systems, assessment, and plan. Be careful of conflicting documentation throughout your progress note. Templates and auto-population of normal effect or negative for depression or denies depression in the physical exam and/or review of systems for depression causes a contradiction. So know your progress note output. Once you've completed your progress note and signed off on it, view the output to ensure it's not bringing in descriptive terms that create a contradiction for the depression. Regarding the CMS criteria MEET, monitor, evaluate, address, treat, a brief example of a great documentation for depression is as follows. Mild, recurrent, major depression, continue Zoloft. That meets the requirement. For diagnosing the severity of major depression, many organizations use the Patient Health Questionnaire, the PHQ-9. The PHQ-9 form used for assessing the severity of depression is based on the DSM-IV criteria for diagnosing major depression. 5 symptoms must be present within a 2-week period. A minimum of 1 has to be a depressed mood or loss of interest, typically the first 2 questions. Documentation must also support that symptoms are causing the patient stress or impairment in important areas of functioning, like social or occupational, not a result of substance abuse or medical comorbidities. Specific to the depression severity in the PHQ-9 scoring, 1 to 4 would be minimal, 5 to 9 would be mild, 10 to 14 would be moderate, 15 to 19 would be moderately severe, and 20 to 27 would be severe. Major depression diagnosis assignment for the episode. Single episode, recurrent episodes, and remission. So single episode is a single episode of major depressive disorder that lasts a minimum of 2 weeks with persistent symptoms through the day nearly every day. An individual may experience only one single depressive episode in their lifetime. Recurrent episodes. Additional episodes qualified by the DSM-IV criteria for major depression must be separated by at least 2 months of the previous episode. And in remission, there's partial remission and full remission. So partial remission is occasional symptoms from a previous episode are in remission, but the full DSM-IV criteria is not met. No symptoms from the previous episode for 2 months. Full remission is still active. Only the signs and the symptoms are gone or controlled. There's no significant signs or symptoms of the depression for 2 months. Whether or not a patient is actively being treated for major depressive disorder, receiving counseling and/or taking antidepressive medication, and the depression is considered stable, documentation of quote-unquote in remission would be appropriate and codable to an active code. The question remains, what if the patient quit the treatment that was in place or quit taking the medications? Will the depression reoccur? So major depression in remission means that the signs and the symptoms of the depression are gone and controlled by the treatment methods that you have in place. Here on the left you see some ICD-10 diagnoses with the descriptors showing you the different selections available for single episode, recurrent episode, and episode in remission. Some common behavioral health coding and documentation opportunities and errors. Many times we see conflicting documentation throughout the progress note. Documentation and coding of mood disorder with normal physical exam or normal review of system findings in the progress note. Many times we see a diagnosis omitted from the claim. Ongoing major depressive disorder is documented throughout the progress note. However, the diagnosis is not in the assessment and not submitted on the claim for submission. Lack of supporting documentation for conditions. Sometimes the condition is simply listed in the assessment and submitted on the claim without clinical documentation evidence of meet throughout the progress note. Remember, the diagnosis, monitor, evaluate, address, treat must be in the progress note. The condition is only listed in the problems list or past medical history but included on the claim. Again, documentation in the progress note must substantiate the diagnosis codes being submitted on the claim. Lack of specificity in the code selection. There's a specific episode or reoccurrence of major depression that's documented in the progress note and in the assessment. However, only major depression not otherwise specified is selected for claim submission. Perhaps F329 is a memorized code for depression, but we need to get the code to the highest specificity documented in the progress note. Some clinical documentation takeaways. Specific to the term history of in your documentation, per the ICD-10 guidelines, a personal history code explains a patient's past medical condition that no longer exists, is resolved and gone. The patient's no longer receiving any treatment or medication for the diagnosis. Current conditions should not be documented as a history of, even when the signs and the symptoms are controlled, not currently present, stable, and still receiving treatment or medications. You'll want to code that diagnosis as depression in remission. Progress note documentation specifics. The use of slashes in your documentation from an outpatient perspective are interpreted as either and or. Avoid using slashes when documenting multiple conditions. Diagnoses documented as rule out, suspect, working, possible. Code to signs and symptoms and not an actual diagnosis. Outpatient documentation is much different from inpatient documentation, so be sure to list an exact confirmed diagnosis and the treatment plan for that diagnosis. In all cases, try to avoid abbreviations, but if you do use an abbreviation, best practice would say to spell that diagnosis out at least one time and then utilize the abbreviation throughout the remainder of the progress note. Specific to the 1, 2, 3s for behavioral health coding, the 1 being status, the 2 being specificity, and the 3 being the treatment plan, ensuring that the current severity and episode, if applicable, is appropriately documented is of utmost importance in behavioral health coding. Use of the terms such as mild, moderate, severe, reoccurrence, and remission status may determine if the diagnosis qualifies for risk adjustment. Use the active medical problems list to your advantage. Add the diagnosis with the full specificity in the narrative to drive your documentation. So here's a situation for major depression, specificity. Moderate, recurrent, major depression is documented in the encounter. However, depression or unspecified major depression is added to the claim and submitted. The recommendation is to ensure that code assignment for depression matches the specificity reflected in the documentation. Updates to the risk adjustment model place greater emphasis on specific documentation for severity and episode when it comes to depression. Major depression without any additional documentation specifics no longer classifies as risk adjustable. Be sure to include mild, moderate, or severe and the status of the reoccurrence, which should be documented if known. Specific to CMS-HCC risk adjustment coding and the impact it can have on risk score, ensure that all diagnoses are documented the highest level of specificity in your progress note, appropriately assigned and submitted on your claim is detrimental to risk adjustment success. Report all chronic HCC conditions a minimum of 1 time per year. Best practice suggests 2 times per year or more. Accuracy of disease burden and risk score is dependent upon the detailed clinical documentation specificity in your progress note for ICD-10 diagnosis code assignment and claim submission. Active medical problems list accuracy is emphasized. Add all chronic conditions and the status conditions to the patient's active problems list to the highest level of specificity in the narrative and use that narrative to your advantage to drive your clinical documentation in the progress note for accuracy. So here is a high-level recap of the information that we shared today. Be sure to incorporate diagnoses from specialist notes into your patient's active medical problems list to the highest level of known specificity and use the descriptive narrative to your advantage. Use the active medical problems list to your advantage by using the descriptive narrative to drive your clinical documentation details in the progress note. Specific to a depression, attention to the term remission, commonly known as resolved and gone. Depression and remission, assign an active F code, not a Z code. The depression still exists, but the signs and symptoms of the depression are in remission, controlled by medication, therapy, and/or other treatment. That concludes our session for today on depression. Thank you for your time. We truly appreciate you. And remember, it's the little changes made now that will make lasting effects in the future.